So moving to my part of the talk, bridging evidence to practice. My objectives are to review current evidence for osmolarity units for peripheral parenteral nutrition and their implications for safe clinical practice, to evaluate recommended dosing strategies for amino acids and lipid injectable emulsions, and to discuss practical approaches to triglyceride monitoring. And how I view my objectives of this talk are really through the lens that we know the importance of early nutrition for preterm infants, and that nutrition in the first 2 weeks of life, making sure that it is quality, helps decrease nutrient deficits, helps to support improved growth, and can help support improved long-term outcomes, including improved neurodevelopmental outcomes. However, we know there's a growing body of literature that I'm not diving too much into today, particularly with amino acid dosing, thinking about that too much might not be great. So really thinking about how we view quality nutrition overall. So to begin with the osmolarity of peripheral parenteral nutrition. And just a quick review to talk about something quite exciting this morning. I can never really remember the difference between molarity and molality. As a dietitian, I'm often talking about osmolality with infant formulas. So this is what I've got. When we're talking about molarity, we're talking about moles per liter. There's an R in liter, and there's an R in molarity. And then molality is the other one. It could be a little more helpful to think about molarity is a bit more intuitive as we're talking about moles of sugar in your liter of coffee that you're drinking with us this morning at 6 a.m. Whereas if we're thinking about the molality of your coffee, that would be moles of sugar per kilogram of coffee, and I don't actually know what that is, right? So osmolarity is the measure of osmotically active particles per unit volume of solution, which is a bit more intuitive as compared to osmolality, which is the measure of osmotically active particles per unit mass of solvent. While osmolality is a bit more specific, less influenced by temperature and pressure, osmolarity is a bit more intuitive, and it's what we're talking about when we're talking about contents within parenteral nutrition. So here we are. I want to know, what is your hospital's osmolarity cutoff specifically for peripheral parenteral nutrition? I'm loving watching these bars dance. I'll answer this question now for myself, and I'll answer it again in a few slides. My unit's peripheral parenteral nutrition cutoff is 1,100 milliosmoles per liter. That can be a little bit attending and case dependent, but that is what our unit's current practice is. I am seeing a large quantity of people who are having that less than 900 cutoff, but of course some moving ranges above that. And I think this really demonstrates that there is variability in clinical practice here. So let's dive into it a bit more. So what are the recommended peripheral parenteral nutrition osmolarity limits? There are several recommendations, and I've included some cutoffs in this slide, but I've also included the language behind them because I think it is important to recognize the strength of the evidence for each of these cutoffs. Because oftentimes in clinical practice, we're just rounding and, oh, we hit our number. And that's it, right? It can feel a very black and white situation. But when we read things like ASPEN's cutoff for 900, there is limited evidence or the evidence to support a safe limit is lacking. And there's variations on that theme when we're viewing these different cutoffs where there is limited evidence. The strength of the evidence is weak. The National Institute for Health and Care Excellence in their 2020 PN guidelines actually didn't give a recommendation, as the committee agreed that it was not possible to recommend a specific safe concentration of peripheral parenteral nutrition because of the wide range of concentrations used in available evidence. So I think it's important to note when we're viewing our own clinical practice that there's a gray area in these recommendations that is worth evaluating. I've included some selected institutional osmolarity limits, including some that were published in the literature, so Wilmington, Delaware, Penn State Health Children's Hospitals, which these are true as of 2013 and 2021 when these papers were published, but we can see quite a wide range. I informally surveyed my colleagues in Ohio a few years ago what they were using for their cutoffs, and it ranged from 900 to 1,200 milliosmoles per liter. My hospital, as I mentioned, uses a cutoff of 1,100, which we had reduced from 1,200 back in 2021 when we initially reviewed the evidence most recently. So when we think about how we evaluate these cutoffs, we need to think about evaluating the risk. So what are some of the risks with providing peripheral parenteral nutrition? We can have occurrence of thrombophlebitis and other line-related events, which can lead to morbidities, including purulent drainage, skin necrosis requiring plastic surgery repair. But what are the risks when we have excessive limitation on our osmolarity within peripheral parenteral nutrition? We can have insufficient nutrient administration, which can lead to cumulative nutrient deficits, which can then lead to growth failure, malnutrition. But when we think about the risks of PPN, oftentimes in the literature, they are evaluated in severity by grade level, with grades 3 and 4 being the most severe. As a dietitian, I don't get to see what this looks like very often, so I've included some visuals of what a grade 3 injury example looks like, which on our left is a stage 3 injury of the left thigh, and on the right is 24 hours after treatment. And then here are two examples of a grade 4 injury, with A showing severe ischemia after PN injury and B showing 26 months after treatment for that injury. C, a stage 4 injury with established compartment syndrome, and D showing 32 months after treatment. And I show these as an important reminder to myself and to you all that the risk is real and there is a real patient impact here. So when I say, let's take a closer look at our osmolarity limits, it's not to dismiss this risk, but also to weigh the risks and benefits of our practice. So I think the big question is, does osmolarity alone drive occurrences of line-related events? Evidence in our NICU population is limited, but worth looking at. In studies published by Cease and Fessler, they did not find a difference in the odds of having a line-related event with differing osmolarity cutoffs of their PPN, using 900 and 1,000 respectively. Dugan et al., which was looking at a pediatric population inclusive of some infants, did see a difference in line-related events, comparing less than or equal to 1,000 or greater than 1,000 as their PPN osmolarity limit. So in the NICU, but also with other pediatric populations, there has been some evidence to show some differences in occurrence. I apologize to this first author, Shenowitz et al. In 2023. They looked at this a bit differently and evaluated in higher versus lower osmolarity, osmolarity cutoffs. They looked at high treatment for events and did not find any difference in treatment. So rather than grading of injuries, the occurrence of treatment for line-related events with higher versus lower PPN cutoffs. And they did not find a difference. Lissa Lamport and her group actually last year presented this data at a poster session here at ASPEN, which is a poster that I really liked. And what they presented was that in mild, moderate, and severe line-related events, there was no difference in the osmolarity of solution of the peripheral parenteral nutritions in their evaluation. Looking a little deeper into their data, good morning, you're here already. I had to remember to turn my alarm off. A deeper dive into Lissa Lamport's data, we can see that more severe line-related events were seen in younger, smaller infants with a longer duration of that peripheral line. We, of course, saw higher rates of treatment and wound care with more severe events. But the takeaway from Lissa's data that has really stuck with me over the past year is that they saw a higher occurrence of medications administered via IV within 24 hours before their line-related event. And I'll come back to that thought in a moment. These data are from Fessler et al. And this group had some interesting takeaways when evaluating the contents within their peripheral PN. They found similar calcium concentrations in infants who had a line-related event and those that didn't. So they were asking, well, does it really make sense to eliminate or reduce calcium content within their PPN based on their own data? Of note, their institution has since implemented a limit of 20 milliequivalents per liter calcium in their PPN since this publication. They found that infants with a line-related event tended to have a higher dextrose concentration. So they hypothesized, should maximum glucose concentration be limited to 11% when providing PPN, irrespective of osmolarity? I don't know what the right answer is. However, when we think about, do we limit nutrients, we can see how quickly restricting osmolarity of PPN limits the quality of administered nutrition. Shanowitz et al. Found that those who had a lower cutoff of their PPN osmolarity were less likely to meet their protein and fat requirements, and were going to receive lower total energy administered when we look at just per IV nutrition components or total nutrition components overall. So considerations in evaluating our PPN practices. Osmolarity is definitely important, and perhaps we should evaluate individual components when we're putting together our PPN. Perhaps we want to consider line location, although there has not been consistent evidence that line location is going to drive line-related events, but perhaps we are a bit more conservative when it's an IV in the scalp. We should be considering the size of baby. We should be considering what's flowing through there. The presence of lipids has been differing in terms of its protective versus not protective impact in terms of line-related events peripherally. I do think we need to be closely considering what else is running through that line, and particularly with the administration of IV medications. Again, Lissa Lamport, her group stated that increased surveillance of IV sites for preterm infants following medication administration may decrease the risk of severe line events. And that has really stuck with me in terms of evaluating my own clinical practice. We do need to individualize our evaluation of this topic with individual patient nutrient requirements and risks, and also in the context of plan for central line access or progression on enteral feeds in order to balance, again, that risk of line safety as well as meeting individual patient nutrition requirements. So, moving quickly along to protein dosing and preterm parenteral nutrition. I'm sure, as we all know, ASPEN published in 2023 an updated recommendation for our amino acid dosing in parenteral nutrition with a recommended goal range of 3 to 3.5 grams per kilo per day, coming into line closer with the ASPEN recommendations published in 2018. This was a big change for my unit, and perhaps for you as well, where we used to just charge right ahead to 4 grams per kilo per day and ignore everything else. So in reevaluating our clinical practice to come more in alignment with these updated recommendations, we've started to really more consider the total macronutrient range of what we're providing in our parenteral nutrition. And so what I've displayed here is just a derived percent energy contribution from macronutrients for the NICE, ASPEN, and ASPEN guidelines. But what I really like to do on rounds is to report our non-protein energy to gram amino acid ratio as a way to help contextualize, are we providing good total nutrition? I'm biased to the 20 to 30 range of non-protein calories per gram amino acid that NICE has presented, and those are in range with ASPEN and ASPEN's derived recommendations as well. And what drove this change in practice is that our NICU, as I mentioned, readily met our dated goal protein intakes for most preterm infants on parenteral nutrition by day of life 5. And this was true if you were very low birth weight or extremely premature. However, our preterm infants were not easily meeting total energy requirements even by day of life 14. And with that, we of course had a really unbalanced provision of nutrition via our parenteral nutrition, with not falling in that yellow range of that 20 to 30 non-protein calories per gram amino acid, meaning we're giving a lot of protein, but we're not balancing that out with nutrition. So what areas did we identify to improve balance of our provided nutrition? We really embraced the new recommendations that required a lot of learning and listening. We've begun to report the distribution of macronutrient energy contributions on rounds. We're starting to talk about evaluating our starter PN practices, ensuring that we're not exceeding our volume limitations of 80 to 100 ml per kilo per day, and exploring potentially modifying our starter PN composition by reducing the amino acid component. We, of course, want to transition to full PN as soon as is logistically feasible to ensure the provision of calcium and phos. And we do want early initiation of IV lipid emulsions. So rather than just thinking about progressing parenteral nutrition by volume, independently of each other dosing lipids and protein, perhaps we should be thinking about parenteral nutrition progression with an evaluation of total composition as a whole, using that non-protein energy to amino acid ratio. And finally, fat dosing in parenteral nutrition. Recommendations for IV lipid emulsions are generally similar. They're going to focus on early initiation, preventing essential fatty acid deficiency, and progressing to a dose of generally 3-ish gram per kilo per day. There has been ample research that early lipid initiation is feasible and safe. Dr. Nagel's group has a great paper kind of displaying this, that early initiation of lipids along with other elevated parenteral nutrition components is possible, even within a very premature group. I'm not going to dive too much into this because the queen of lipids is here, but when we think about the proposed clearance rate for lipids, there's a proposed rate of 0.15 gram per kilo per hour. And that comes from and thinking about our triglyceride limitations, that lower level is kind of theoretical due to presumed lower activity of lipoprotein lipase. So, how does your NICU define hypertriglyceridemia? I'm excited to see these answers. And I see that it's not an option here, but if you're feeling brave, could you raise your hand if your NICU doesn't have a definition for hypertriglyceridemia? I'll raise my hand. Cool. Thanks, friends. So I'm seeing, all right, 400's quickly dropping. I was about to draw a conclusion. So there is a range here. 400 surging back. This is too fun to watch. Moving forward. There is no unified definition of hypertriglyceridemia in preterm infants. We have some listed ones where neonatal ranges are going to be lower than the pediatric definition. But if you see how literature or research, I should say, defines hypertriglyceridemia, there's quite a range. And if you've read my research, you know I love a survey. And this survey by Gabriel et al. Was evaluating hypertriglyceridemia practices within NICUs, and you can see the variation of ranges of how individuals and individual NICUs defined hypertriglyceridemia. You can also see similarly quite a range of when individuals are checking triglyceride levels. And this is an intentionally busy slide because there is no standard limited agreement. When to obtain a triglyceride level? I don't know. Fasting or non-fasting? There is variable evidence to support that you will find a clinically meaningful difference in getting a fasting triglyceride versus unfasting level. Some strategies for nutrition management in the setting of hypertriglyceridemia. I focus on the logistical and making sure we're meeting essential fatty acid requirements. Ensuring that triglyceride level is not contaminated is a big point of discussion in my unit. And running lipids over 20 to 24 hours, ensuring our dextrose infusion is not excessive. There are some parenteral nutrition considerations that hypothetically could have an impact in limiting hypertriglyceridemia, including carnitine, maybe calcium, maybe lipid selection, but the evidence for those interventions is moderate at best. So my considerations of lipid dosing and monitoring is that meeting essential fatty acid requirements is truly essential. And noting that hypertriglyceridemia can be present in essential fatty acid deficiency, so don't let that be your marker for waiting to start lipids in a 22-weeker. There's a continued need for evaluation of hypertriglyceridemia monitoring and interpretation. So my takeaways for clinical practice: we need to evaluate PP and osmolarity limits. We need to consider proportions of macronutrient energy when evaluating PN support. Meeting essential fatty acid requirements is key. There's not one agreed upon method for hypertriglyceridemia monitoring or assessment. And parenteral nutrition practices at the institutional level should be routinely evaluated to ensure they are evidence-based and supporting ideal infant care, and not just because, well, that's the way we've always done things. So these are some of my references. Thank you for your time this morning.